discussed in India, 1 in 4 death due to CVD. Urban, it's come to urban, 10 to 12%. Adult may have heart disease. Rural India, 4 to 6% adult affected. My point is no one is safe. So the point is the burden is shifting to younger age groups in India. India has one of the highest burden of heart disease globally. Coming to heart anatomy, if you are going to study any kind of any system, the anatomy is very important. So let's say quick review on anatomy of heart. Heart anatomy, approximately the size of 250 to 300 grams. All of you knows. Locations in the mediastinum between the lungs, superficial surface of diaphragm, 2/3 of its lies to the left of the mediastinal line. It's around 90% and 10% is from the right of the middle sternal line also. It's called dextrocardia. Anterior to the vertebral column, posterior to the sternum. It's a location of heart. Okay, again, the heart anatomy, you can see here in between the two lengths, heart is situated. Okay, just above the diaphragm is slightly left deviated to 90% people and 10% people. It is slightly right deviated. It's called a dextrocardia. It's a normal condition. Okay, the layers of heart is coming to a pericardium, a double walled sac around the heart, composed of a superficial fibrous pericardium, two deep layers of serous pericardium. The parietal layers lines the inner surface of the fibrous pericardium. The visceral layers of or epicardium lies the surface of the heart. They are separated by a fluid-filled pericardial cavity called pericardial cavity. Protects and adheres the heart, prevents overfilling of the heart with the blood, allows the heart to work in a relatively friction-free environment. This is very important. It's a friction-free environment. Okay, this is a pericardial layers of the heart. Okay. Next is epicardium, visceral pericardium. It's next is myocardium, the cardiac muscles. The major role of muscle, it's myocardial muscles. Heart endocardium is an inner layer of the myocardial surface. Okay. Again, the external markings, the heart can be divided two parts, the apex and the base. Apex is pointed at the inferior region and the base is the upper region. Again, coronary solus, inductions that separates atria from the ventricles, anterior and posterior interventricular sulcus. Separates the right and left ventricles, internal divisions, atria superior and ventricle inferior, interventricular and interarterial septal. Okay. Atria receive the chambers of the blood of the heart, receive the venous blood returning to heart, separated by a internal arterial septum. It's a wall. Foramen ovale opening in the internal arterial septum in fetus. Foramen forosa ovale is remnant of foramen ovale. Each atrium has a protruding auricle. Penetrate the muscles marks atrial walls. The pumps blood into ventricles. Blood enters the right atria from the superior and inferior vena cava, and the coronary sinus. The blood enters the left atria from the pulmonary veins. Okay. This is the structure of heart from inner side. We can see the two atriums. One is the right side and one is the left. And the below it's two ventricles. It's the right and left ventricles. It is separated by the septums. Okay. Again, coming to the ventricles are the discharging chambers of the heart. It's the powerhouse. We can say it's a powerhouse of heart, separated by an interventricular septums. Right ventricles pumps blood into the pulmonary trunks. It goes to the lungs for the oxygenated bloods, and coming to the left ventricles pumps blood into the aorta for the circulation of the entire body. Okay, this is the outer structure of the heart. We can see here the coronary arteries. There are three coronary arteries, right coronary arteries, left anterior descending and left circumflex. These are the arteries supplies blood for the heart. Okay. The left ventricles, this again, I am saying this, the main powerhouse of the heart is the left ventricle, 3 times thicker than the right, exerts more pumping force, flatten right ventricles into a certain shape. Okay, again comes to the walls of heart. The heart walls ensure unidirectional blood flow to the heart, composed of an endocardium with a connective tissue or the two major types, atrioventricular valves and semilunar valves. Atrioventricular valves lies between the atria and ventricles. Right atrioventricular valve, it's called a tricuspid valve or nose. The left atrioventricular valve is a bicuspid or mitral valve. The AV valves prevents the backflow of blood into the atria when ventricle contracts. Okay, and then the prevents collapse of the valve back to the atria. Okay. In the coming, so semilunar valves prevents backflow of blood into the ventricles, have no choroid tendinite attachments. Aortic semilunar valves lies between the ventricle and the aorta. Pulmonary semilunar valves lies between the right ventricle and the pulmonary trunk. The heart sounds lub dub due to the valves closing. Lub means the closing of atrioventral valves, and dub means the closing of semilunar valves. If you are going to auscultate the heart sounds, you can say you can hear the sound of laptop. Okay. Again, coming to the conductive system of the heart, generates, okay, cardiac muscles tissues have interesting ability to generate and conduct impulses, signal these cells to the contract rhythmically. Conducting systems, a series of specialized cardiac muscle cells, a sinoatrial node, SA node sets an inherent rate of contractions. It's a pacemaker of heart, it's a sinoatrial node. Okay. Again, the heart rate is altered by some external controls. Nerves to the heart includes the parasympathetic sympathetic branches and sympathetic fibers. Okay, in coming to the parasympathetic branches of vagus nerve, if the vagus nerve is stimulated, if the patient is come with an vasovagal episode and sympathetic fibers from the cervical and upper thoracic ganglia. Okay. The major vessels to the heart, vessels returning blood to the heart includes a superior and inferior vena cava. Opening to the right atrium, return deoxygenated blood from the body cells, coronary sinus. Its opening to the right atrium returns of deoxygenated blood from the heart muscles, coronary veins. Right and pulmonary veins opening to the left atrium, returning oxygenated blood from the lungs. These are the major vessels of the heart. Again, the major vessels of heart conveying blood away from the heart include the pulmonary trunk, carries a deoxygenated blood from the right ventricle to the lungs, split into right and left pulmonary arteries. This is one arteries carrying deoxygenated blood in our body. Ascending aorta carries oxygenated blood away from the left atrium to the body organs. The major branches, brachiocephalic, left common carotid, and left subclavian arteries. Okay, this is the entire circulation of body, systemic circulations, we can say, pulmonary circulations also. Okay. The red, we can say it's oxygenated blood, and blue color, we can say it's an deoxygenated blood. If any of the organ stops, the cardiac arrest will be the result. Okay. Okay, this is for the coronary circulation, arterial supply. Okay, here we can see the aorta, pulmonary trunk, left coronary arteries, left atrium, left circumflex artery, right ventricle, left ventricle, anterior intraventricular artery, posterior intraventricular artery, marginal artery, right atrium, right coronary artery, and anastomosis and severe vena cava, superior vena cava, sorry. Okay, again, this is the venous distribution of veins of heart, the great cardiac vein, the venous veins that carries deoxygenated blood from the heart. Okay. Am I audible?
Yes, sir, you are audible.
Okay, okay. Okay. In between any issues, you can interrupt me. Okay.
Okay, sir.
Okay. Okay. Here comes classification of cases. This is very important. While we are entering to the cardiovascular diseases, there are two types of
हेलो सर, आपकी आवाज नहीं आ रही है। हेलो सर।
Make a call, I think disconnected.
Yes, ma'am.
No issue, you will join back.
Am I audible, sir?
सर आप म्यूट हैं.
Am I audible now?
Yes, sir.
My screen is visible?
Yes, sir.
Is changing?
Yes, sir.
Okay.
Now it's changing.
Okay. Okay, non-life-threatening situation, I will explain again. Okay, there are two situations. One, the patient is stable and one is unstable. So these are certain criteria to define whether the patient or client is stable or unstable. The first is whether the patient have a signs of hypotension. The patient is unstable. Any signs of shock. The patient is unstable. Any signs of any chest discomfort. The patient is complaining about any chest discomfort, any chest pain. The patient is considered as an unstable. Any altered mental status with a semi-conscious, unconscious, or patient is disoriented. So we can consider the patient as an unstable. And last is any signs of heart failure. So there are 5 parameters. If any of one parameter is positive, we can consider the patient as unstable. So the patient with VT with a pulse, there is no signs of any unstable parameters. Then we can consider the victim as a stable situation. SVT, again, supraventricular tachycardia, atrial fibrillation, atrial flutter, AV blocks. So if the patient is coming to with these type of ECGs, we have to check the criteria for a stable, unstable situation. If the patient is unstable, we have to intervene as early as possible. Otherwise, it can be converted into a life-threatening situation. Okay, if any of these positive, we can consider as an unstable patient. Okay, this is a very important slide. Okay, next is ECG. You have a major role in cardiovascular disorders. Okay, I know ECG is very difficult to learn, but I will try my level best. Okay, it's a graphical recordings of electrical potential generated by the heart. Okay, very clear. It's ECG can give you only an electrical potential of a heart. It cannot give any kind of physical activity of heart. Okay, don't blindly believe the ECGs. ECG can show any normal activity, but if there is a no pulse, it's only considered as a pulseless electrical activity. Okay, my point is if there is any deviations from any kind of changes in ECG in monitor, go and check for the pulse physically. Okay, ECG shows only the electrical potential generated by the heart. It doesn't mean patient heart is normally contracting. Okay. Activation of the heart. Okay, again, the SA node. SA nodes, the impulses will comes and it's normal as the normal pacemaker of the heart. From the SA node, it goes to the AB node. Then the bundle branches, then to the Purkinje fibers. Okay, so this is the normal conduction system of the heart. The ECG comes with a normal P wave, QRS, and T waves. Okay, so the P indicates the functioning of the atrium, means the electrical supply in the atrium. QRS complex, it indicates the electrical conductivity of the ventricle, and T is a relaxation of the heart. There are some intervals we can see in the ECG. One is the QT interval, one is the PR interval, one is the QRS, one is PP, and one is the RR intervals. There are some segments also, the ST segments, RS and ST junctions and J points are the segments in the ECG. Okay, the important one is the PR intervals and RR intervals is very important. Okay. Representations I already discussed. The P wave shows the conductivity of the atrium. It includes the depolarization of atria in response of SA node triggering. PR intervals, it is the impulses, the traveling of impulses from the atrium to the ventricle is the PR interval. QRS complex indicates depolarization of the ventricles, triggers the main pumping the contractions. Okay. T wave, the ventricular repolarization, and XT segments, it's the beginning of ventricular repolarization should be the flat. If there is any ST elevations, it can be considered as an MI. Okay. Coming to the ECG paper, all of you have seen the ECG paper. It's something like a graphical representations. Okay, it consists of, there are small squares and big squares. Wait. So there are so many small squares and big squares. Each big squares carries 25 small squares, and one small squares the time for one impulses to cross one small square carries 0.04 seconds, and one big squares it takes 0.2 seconds. Okay. Okay, we can calculate the ECG heart rate from an ECG while by counting the RR intervals. There are total 300 big squares in an ECG papers, and there are 1500 small squares in an ECG paper. Okay, let's see how we have to count the heart rate from an ECG paper. See, we can see the RR intervals. This one is the R wave, and this one the R waves. Okay, there are some big squares in between the RR intervals. There are 1 big square, 2 big square, 3 big square, 4 big squares. Okay, so we can count the big squares in between the RR intervals and divide by the 300 will be the heart rate. Okay, see, this is the 2 RR intervals. Okay, 1, 2, 3, 4. Okay, there are 4 big squares. Okay, sorry, 5 big squares. In between there are 5 big squares. 1, 2, 3, 4, 5 big squares. Okay, the 300 divided by 5 will be the heart rate. Okay, 300 divided by 5, 60 is the heart rate. While we are going for a small squares, we have to count 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. You have to count entire 5 big squares. Sorry, you have to count entire small squares in between RR intervals, and you have to divide it with 1500. That will be the heart rate of ECG. Okay. Okay, small box methods I already discussed with you. You have to count entire small squares in between RR intervals, divide by the 1500. Okay. NSR parameters means normal sinus rhythm parameters. Okay, what are all the things we need to check in an ECG paper? Well, the first one is the heart rate. The normal, you all know, the 60 to 100 is the normal heart rate. So we can count from an ECG paper the how many big squares in between the RR intervals. That will be the heart rate. Okay, you should divide with that by the 300. Next, we have to go for the regularity of rhythm. Okay, by checking the RR intervals. 1 R, second R. How many square? 1, 2, 3. 1, 2, 3. 1, 2, 3. Then every RR intervals carries 3 big squares in between. So we can say the RR interval is regular. Okay, RR interval is regular. That means the heart rate is regular. Next, P waves. We have to check whether the P wave is present or not. No, see, this is the P wave. 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 We can see all QRS complex. We have a P before that. Okay, then the P wave is normal. Then we can go for a PR intervals. PR interval, there is some we have to notice the PR interval normal time is 0.12 seconds to 0.2 seconds. I have told you people the small square carries 0.04 seconds time. Okay. So each small square carries 0.04 seconds, means one big square carries 0.2 seconds. So the PR intervals mean when the P wave starts and the P wave, and sorry, 1 second, when the P wave starts and it goes to the starting of the R wave. Okay, that's a PR interval. The time from P starts to the R starts. Okay, so the normal timing is not more than 5 big squares. The normal is 3 big squares, or 3 small squares to 5 small square is the normal of PR interval. Okay, it won't be more than 5 small squares or 1 big squares. Okay, that's a normal range. Again, the QRS duration, QRS duration is the QRS complex space. So it's the normal range is 0.04 seconds to 0.12 seconds. Means one small square is the normal of one normal square, one small square to 2. Your 3 small square is the normal size of QRS complex. Okay, this is a little difficult but easy. Okay, normal sinus rhythm. What all the things we need to check? We have to check whether the P wave is present or not. Yes, the P wave is present. Next is PR intervals. We can count it. Okay, we can count from here. Okay, 1, 2, 3, 4, 5. Okay, 5. We have seen the 5 small squares. Okay, the PR interval is normal. Okay, next we have to check for the RR intervals. 1, 2, 3, 1, 2, 3, 4, 1, 2, 3, 4. Okay, these are regular. Okay, RR interval is regular. Next, we can go for the QRS complex, wide or narrow. Wide means QRS complex more than 3 small squares. Okay, we can see one small square is here. The gap of QRS complex is one small square. Okay, it's normal. Next, we have to go for ST elevation. This is the T and this is, sorry, this is the S and this is the T. Okay, we can see there is no ST elevation. So this ACG is considered as a normal. P wave is present. PR interval is normal. RR interval is regular. QRS complex is normal and ST, no ST elevations, no ST depressions. So we can consider this ECG as a normal sinus rhythm. This is the technique of analyzing or interpretation of a simple ECG. There are 5 steps. One is whether the P wave is present or not. Next is whether the PR interval is prolonged or not more than 5 big squares. And next is RR intervals, regular or irregular. Next is QRS complex, not more than 3 small squares and not less than 1 small squares. And last one is ST segments, elevation or a depression. So this is the 5 key steps for analyzing an ECG. Okay, this is normal sinus rhythm. Okay, we can see again, this is the P wave is present, PR interval is normal, or RR interval is again regular. Okay, we can see 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Okay, the RR interval is regular. Okay, again, QRS complex width is okay. We can see one small square is there. Okay, it's a normal. And this is the S and this is the T. There is no ST elevation. S is on the normal range and T is some tall T waves is there, maybe hyperkalemia. Okay, it's also okay. This is a normal sinus rhythm. Okay, then the classification of tachycardia classifications on the based of origin. Whether the tachycardia is originating from the atrium, it's called atrial tachycardia. It's originated from the ventricle, it's called a ventricular tachycardia. Okay, what are the atrial tachycardias? One is the sinus tachycardia. Second is atrial tachycardia, atrial flutter, atrial fibrillations. These are the tachycardia from the side of atrium. From the side of ventricle, there are ventricular tachycardia with pulse, without pulse. Without pulse is again dangerous. We have to start the CPR and shock and the cardiac arrest management. Ventricular fibrillation, again cardiac arrest situation, you have to start with the CPR and epinephrine as early as possible. Okay, okay, this is algorithm. We can say your there is any okay. If you are seeing a tachyarrhythmia, okay, tachyarrhythmia means the heart rate is more than 150. We can say it's a tachyarrhythmia. Arrhythmia means abnormal ECG. So if you are seeing a tachyarrhythmia, the heart rate is above 150. So first of all, we have to check the QRS complex. Okay, QRS complex wide or narrow. Wide means more than 3 small squares. Narrow means less than 1 small square. Okay, first let's see. We got an tachyarrhythmia about a heart rate of 200. Okay, this is a tachyarrhythmia. First, I will see the QRS complex. Okay, oh, it's a wide QRS complex. Then I will see is it regular or irregular. Okay, I see it's a regular. Regular means only one situation. It will be a VT, ventricular tachycardia. Again, ventricular tachycardia of 2 types. According to the morphology of that ECG, monophobic or polyphobic. Okay. So it's a mono means its the morphology will be same, and poly means its the morphology will be different. Okay. Again, it's a suppose it's irregular QRS complex. QRS complex is not regular; it's irregular. So only one situation there is a VF, ventricular fibrillation. It's also again divided into 2 types. One is Horace and one is fine. So, in later slides, I will discuss what are all those things. For suppose I saw the QRS complex is narrow, then again we have to go for regular and irregular. Okay, regular means the P wave is normal. We can say it's a sinus tachycardia, or a sawtooth wave. It can be a atrial flutter. Irregular is only one situation, atrial fibrillation. Okay, see, this sinus tachycardia. Sinus tachycardia, see the QRS complex. Okay, QRS complex is 2 small squares. Okay, it's narrow only. It's a normal thing. Next is right regular. It's a regular one. So P is present. So we can say it's a sinus tachycardia. Okay, C. Sinus tachycardia. Next, SVT. Supraventricular tachycardia. See, there is no P wave. P wave is there, but it can't be seen in ECG. See, this ECG, there is no P wave. We cannot identify is a P, but P is present. It is masked by the T wave. So then next we have to check for the regularity. All the R waves are regular. The heart rate will be 180. So we can say it's an SVT. SVT. Okay. That is atrial flutter. Okay. Atrial flutter. So there are so many flutter waves. This is the multiple P waves. We can say it's a sawtooth waves. Sawtooth waves. Yeah, for it's something look like teeth of a fish. Okay. So it's commonly in between the RR intervals. This is called F waves, it's a flutter waves, but the RR intervals will be regular. We cannot say it's as a P wave, but it's look like a P. It's called a flutter waves. This is the atrial flutter. This is the C. It's like a flutter waves. Okay, flutter waves. Atrial fibrillation, it is very easy to identify atrial flutter because the heart rate is very fluctuating. Sometimes it shows 90, on the next second or fraction of seconds, it will show 150, 150 to 120, 120 to 80, 80 to 110, 110 to 160, something like there's a huge fluctuation. So the reason for the fluctuation is the irregularity of the RR interval. See, one R is here, one R is here. See the gap, 1, 2, 3 big squares. 1 R, second R. See the gap? 1, 2. 1, 2, here 1. So the RR interval is irregular and there is no P wave. No P wave. This all we are seeing is T wave. No P wave, no P wave, no P wave. So the significance of this atrial fibrillation is will be no P wave and RR interval will be irregular. Okay, see this. This is a T wave, no P wave, T wave, again no P wave. And see the difference? RR intervals is irregular. Gap is more here. Here the gap is less. Here is or more. So the RR interval is irregular and there's no P wave. It's called atrial fibrillations. I can come into the ventricular rhythms. So my speed is okay. Hello.
Yes,
Hello.
sir.
Am I okay?
Yes, sir. You are audible.
Yes, speed is okay.
Yes, sir.
Okay.
Little bit fast, but we cannot do LB because you have lots of topics to be covered
Yes,
in 2
that's my
hours.
ma'am. Yeah, my
But
intention is
the topics you really needed very much description. You just take a break and explain, such as you are explaining waves like this, Hana. So maximum, I must say that maximum students, they are having purely new experience with this, and they will be very
okay.
happy if you are getting them a clear picture. So you can focus on these things little bit more. Okay. And
Okay,
some
okay.
common topics you can viva off, no problem. But these topics you
Yes,
can
yes.
clear them, है ना?
Yes,
Okay,
okay,
okay.
ma'am. Okay, ma'am. Okay, ma'am. Thank you, ma'am. Thank you for the feedback. Okay, coming to the ventricular tachycardia. Ventricular tachycardia is originating from the ventricle only. So these are the ventricle rhythms. See, these are the ventricle rhythms. The QRS complex, the gap of the QRS complex. See, 1, 2, 3, 4 big small squares. So the QRS complex is wide, more wide. So something serious. When the QRS complex is narrow, the patient is in a safe zone. Okay, but the QRS complex size is more. The patient is in a critical stage. The patient is sick. We need a prompt or fast interventions. Okay. So see, this is the morphology. See the morphology is the pattern. See, it's the same like it's a monophobic VT. Ventricular tachycardia, the pattern, the M type pattern, the M, same. It's a regular. It's called a polymorphic. Okay, polymorphic VT. Okay, polymorphic VT, the same pattern, and QRS complex is white. Okay, see, this is the pattern. This is something different pattern. Okay, there is a M, or this is a small type M. Again, big M. Okay, small pattern. Again, small. The pattern is frequently changing. It's called the polymorphic VT. Okay, this is irregular, and this one is regular. Okay, irregular, polymorphic VT. Okay, these are the shock coupled rhythms. We can see ventricular fibrillation. Ventricular fibrillation is this is okay. See, there is no pattern, no pattern. See, something like a big M, but it's not a constant pattern. This small, very small. Again, is a big M and it is slightly changing. Again, there is no particular patterns. We call the horrors. It is something like, have you seen the earthquake meter, something like that. So this is Horace ventricular fibrillation. So in this situation, we need a CPR and shock and medication. Medications means adrenaline 1 mg. Okay, ventricular fibrillation, Horace. Okay, this is a fine VF. There is no particular pattern, but something like that is a small. It's a fine VF, fine ventricular fibrillation. It's also a cardiac arrest situation. So what is needed is we need a CPR, we need a defibrillation, shock, we need a medication. Okay, this is a ventricular fibrillation. Next is non-shockable rhythms. Non-shockable rhythms is something like pulseless electrical activity. See, everything is here. There's a P wave, there's a PR interval is normal, QRS complex is normal, RR interval is irregular, no issues, no ST elevations, P wave is also, everything is there, look like same, but it's their patient don't have any pulse. It's a cardiac arrest situation. So again, I'm saying any changes in the ECG, you have to check the physically pulse on carotid artery for unconscious victim. If there is no pulse, start CPR. The situation is called pulseless electrical activity, PEA. The ECG can be look like normal, but is a no pulse called pulseless electrical activity. The intervention should be start CPR immediately and no shock, and we have to go for the epinephrine as early as possible. Okay. Again, second ECG, it's also look like same, but no pulse, you have to start the CPR. Okay, this must be you people saw in a TV or any YouTube situation. If any flat line, patient is dead. Are you sure? Are you sure? Patient is dead? No. If ECG electrodes is misplaced also, if ECG electrodes is disconnected also, monitor show this line. So if you see saw this line in your monitor, you have to check for electrodes first if the leads is properly placed. Okay, this condition is asystole. Again, your no pulse, start CPR immediately and go for the epinephrine first. Okay, sinus bradycardia. Again, sinus bradycardia means heart rate below 60 and the heart rate below 50 called we can say it's as a bradyarrhythmia. Arrhythmia means abnormal ECG. If the heart rate above 150, we can say it's a tachyarrhythmia. If the heart rate below 50, we can say it's a bradyarrhythmia. Okay. The heart rate above 140 or heart rate up to 140, we can say sinus tachycardia. Heart rate above 150, tachyarrhythmia. Heart rate below 60, we can say bradycardia. Heart rate below 50, we can say bradyarrhythmia. Okay. See. How many big squares in between? 1, 2, 3, 4, 5, 6, 7. So means how many big squares is increasing? It will lead to a bradycardia. Okay. Again, this also the classification of bradyarrhythmia. Coming to brady, we have to focus on the P and QRS complex. Okay, the first is whether there is a P wave and QRS complex is present. Okay, then we have to go for the PR interval. PR interval, if the PR interval is prolonged, PR interval, the gap between P and QRS complex is more than 5, we can say it's a first AB block. If it is a normal, we can say it's a sinus brady. Okay. And in case of after 2 or 4 P waves, PQRS complex, one QRS complex is dropped, we can go for a second AV blocks. There are 3 AV blocks, first degree, second degree, and third degree. So the first degree, we are totally focusing on the PR interval. In first degree, PR interval prolongations will be constant. There is no change in the PR interval. It's maybe above 5 or 6 small squares in between P and Q R wave. So it's a first degree AV block. In case of while in coming to the second AV blocks, QRS complex will be dropped after 4 or 3 PQRS complexes. Let's see the second degree AV block. Again, PR interval prolonged. PR interval is progressing, means the first wave will be normal, second will be prolonged, third will be more prolonged, fourth will be more prolonged, and the QRS complex will drop. It's called a type 1 second degree AB block. And coming to the second type, PR intervals remain constant, but after 2 or 3 PR intervals, one QRS complex will be dropped. This is a second type. And this third type, third degree AB blocks, there is no relationship between P and QRS complex. Means there will be multiple P waves or multiple QRS complexes. There is no relationship. Normally, yeah, ideally, every P wave should be followed by a QRS complex. But in this case, there may be multiple P waves, 2 or 3 P waves, and one QRS complex, or maybe 2 or 3 QRS complex, one P wave will be there. So there is no relationship with the P and QRS complex. So this is a little complicated. I will tell one story regarding this. Ma'am, can I tell the story in Hindi for the students? They will entertain very well.
They will be very happy because a long
Okay.
time they're listening only English. Yes,
Okay.
yes.
Okay. Yeah, attention seeking is very important. Okay, so students, the story is something like that. एक couple का शादी हो गया है. So we can imagine the P is wife and QRS complex is husband. इस दोनों का शादी हो गया है. तो P हमको वाइफ बोलते हैं और QRS कॉम्प्लेक्स हस्बैंड है. तो नॉर्मली क्या होना चाहिए, जो लाइफ में थोड़ा सा शादी हो गया तो अच्छा प्यार होना चाहिए. P के साथ हमेशा QRS कॉम्प्लेक्स घूमते रहता है. ठीक है. तो पहले का फर्स्ट ईयर जो शादी हो गया, पहले साल अच्छे से घूमने जाएंगे, टीवी जाएंगे, और जॉब के लिए जाओगे तो सुबह 8 बजे जॉब के गया और शाम को 5 बजे घर आ जाएंगे. ठीक है, ऐसा रूटीन अच्छा चलता है. ठीक है. और दिस इज कॉल्ड नॉर्मल साइनस रिदम. मीन्स हस्बैंड सुबह जॉब के लिए गया 8 बजे और शाम को 8 बजे, सॉरी, शाम को 5 बजे वापस आ गया. ठीक है, इससे नॉर्मल. इन केस शादी हो गया, 2 साल हो गया, 2 साल हो गया, तो सुबह 8 बजे जॉब के लिए गया और शाम को 5 बजे आना था, लेकिन वो रोज 6 बजे आ रहा है. तो PR इंटरवल जो हस्बैंड वाइफ की जो गैप है वो बढ़ गया. मीन्स वो पूरा ईयर या पूरा हफ्ते भर के या महीने भर ये 6 बजे आ रहा है. सुबह 8 बजे आ रहा है जॉब के लिए, शाम को 6 बजे आएगा. तो ये फर्स्ट डिग्री एबी ब्लॉक. मीन्स PR इंटरवल इज कॉन्स्टेंटली प्रोलॉन्ग. ओके. अब 2-3 साल हो गया, 3 या 4 साल हो गया है, तो 4 साल हो गया, तो मंडे सुबह 8 बजे जॉब के लिए गया और शाम को 5 बजे आ गया. ट्यूसडे सुबह 8 बजे जॉब के लिए गया, शाम को 6 बजे आ गया. और वेनसडे सुबह 8 बजे गया, शाम को कितना बजे आना चाहिए, 7 बजे आएंगे. वो धीरे 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 बढ़ रहा है. और थर्सडे सुबह 8 बजे गया, शाम को वापस आया नहीं. मीन्स वहां पर हस्बैंड नहीं आया. मीन्स QRS कॉम्प्लेक्स ड्रॉप हो गया. मीन्स वहां पर जो गैप है बढ़ते 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 जा रहे हैं, टाइमिंग का बढ़ते बढ़ते, और QRS कॉम्प्लेक्स गायब हो गया. मीन्स हस्बैंड आना था 5 बजे, लेकिन पहले दिन 5 बजे आ गया, दूसरा दिन 6 बजे आ गया, तीसरा दिन 7 बजे आ गया, और उसके बाद वाला दिन में वो आया नहीं है. तो सेकेंड डिग्री एबी ब्लॉक टाइप 1. ओके. नेक्स्ट टाइप 2. टाइप 2 में क्या होगा, सुबह 8 बजे जा रहे हैं मंडे और शाम को 5 बजे आ गया. ट्यूसडे सुबह 8 बजे गया, शाम को 5 बजे वापस आ गया. वेनसडे सुबह 8 बजे गया, शाम को 5 बजे वापस आ गया. अब थर्सडे सुबह 8 बजे जॉब के लिए गया, शाम को चुपचाप आया नहीं है. दिस इज टाइप 2, सेकेंड डिग्री ब्लॉक टाइप 2. PR इंटरवल्स जो गैप है कांस्टेंट रहेगा, और आफ्टर 3 और 4 कॉम्प्लेक्सेस QR कॉम्प्लेक्स आएगा नहीं. ठीक है, दिस इज टाइप 2. अब टाइप 3, सॉरी, थर्ड डिग्री में क्या होगा. अब ये 7 साल हो गया या 10 साल हो गया, शादी के बाद 10 साल हो गया, तो क्या होगा, प्यार उतना रहेगा, कम हो जाएंगे. तो क्या होगा, हस्बैंड और वाइफ अलग अलग कमरे में है, देयर इज नो रिलेशनशिप. हस्बैंड को नहीं पता वाइफ कहाँ जा रहा है, वाइफ को नहीं पता हस्बैंड कब आ रहे हैं. ठीक है, दिस इज स्मॉल स्टोरी. ओके, यू कैन रिमेंबर लाइक दिस. ओके. Okay, heavy blocks I already discussed. Okay, first degree heavy blocks, okay, discussed. Okay, see the second degree heavy block, type 1. See here the PR interval is normal. यहाँ पे गैप बढ़ गया है, यहाँ पे और बढ़ गया है. आप देखो P आ गया, यहाँ पर QRS कॉम्प्लेक्स गायब हो गया. आप ये कहानी सुनो, सुबह 8 बजे गया, शाम को 5 बजे वापस आ गया, नॉर्मल. सुबह 8 बजे गया, शाम को 6 बजे आ गया, बढ़ गया है. सुबह 8 बजे गया, 7 बजे आ गया, बढ़ गया, और यहाँ पर आया नहीं है. दिस इज द सेकेंड डिग्री फर्स्ट मोबिट्स 1 बोलते हैं उसको. ओके. सेकंड, दिस है टाइप 2. टाइप 2 में देखो PR इंटरवल इज रिमेन कांस्टेंट, सेम है, यहाँ पे भी सेम है, यहाँ पे भी सेम है, लेकिन यहाँ पे देखो QRS कॉम्प्लेक्स गायब हो गया. अगर वो सुबह जॉब के लिए गया तो शाम को वहां 5 बजे आना है तो 5 बजे आएंगे, अदरवाइज नहीं आएगा. या देखो मल्टीपल पी वेव, 2 पी वेव है, यहाँ पे QRS कॉम्प्लेक्स आना था नहीं आया, यहाँ पे भी नहीं है, आना था आया नहीं है. यहाँ पे नॉर्मल नॉर्मल नॉर्मल, यहाँ पर P QRS कॉम्प्लेक्स नहीं है, P QRS कॉम्प्लेक्स नहीं है. उससे सेकंड डिग्री टाइप 2. एंड थर्ड डिग्री आप देख सकते हैं मल्टीपल पी वेव्स है. ठीक है, देयर आर मल्टी, दिस इज अ पी वेव, दिस इज अ पी वेव, again this is normal, this is a P wave, here is no P wave. There are multiple P waves and QRS complex is not correlated with the P. Atrium and ventricle have no relationship with each other. Okay, this is a third degree block. Okay, here comes some common diagnostic evaluations for cardiovascular diseases. So students, you can note these points. So there are some common diagnostic evaluations you can memorize. Okay. Introduction: cardiovascular diseases require accurate diagnosis for timely management. Diagnostics help evaluate cardiac structure, function, electrical activity, blood flow, and vessel condition. Okay. It can be divided into 2 types. One is non-invasive diagnostics test and invasive diagnostic test. Okay, we can discuss what is non-invasive. First is ECG. Second is echocardiogram. Third is chest X-ray. And fourth one is stress test, yeah, TMT. Fifth one is Holter monitoring, and sixth is CT scan and MRI. These are the non-invasive diagnosis test for CVDs. Okay. ECG सबको मालूम है क्या करता है? Records electrical activity of the heart, detects arrhythmias and MI, ischemia. For these kind of signs and symptoms, you have to go for ECG. Echocardiogram is called the ultrasound of heart, shows chamber sizes. हार्ट का चेंबर्स का साइज हमको बताएगा ये चीज. वाल्व फंक्शंस, इजेक्शन फ्रैक्शन मींस द पावर ऑफ लेफ्ट वेंट्रिकल टू पंप द ब्लड मींस कार्डियक आउटपुट, कितना ब्लड पंप कर रहे हैं, दैट्स कॉल्ड इजेक्शन फ्रैक्शंस. नॉर्मल 60% के ऊपर आना चाहिए. ये सब अपन को echocardiogram से यू कैन फाइंड आउट. टाइप्स transthoracic and transesophageal, these are 2 types of echocardiograms. Okay. TMT evaluates heart response to exercise or stress, means if we are giving some loads to the heart, then what is the functioning of the heart. So this test called as trust test or TMT. Monitors ECG and BP during the treadmill activities, used in a diagnosis of ischemic heart disease. Okay. Holter monitoring, 24 to 48 hours ECG monitoring. It's a small device. It can fix on your patient's body and tell the patients to go home and come after 2 days. So we can record entire ECG of the 2 days, and we can interpret on what situation or what condition patient ECG is got any abnormalities. Okay, so Holter monitoring. Chest X-ray and cardiac CT MRI. Chest X-ray shows the heart size, if there is any cardiomegaly, lung congestions or great vessels, any kind of aorta abnormalities, something like that. CT MRI, detailed structure, plaque masses. If you go for an angio CT or angio MRI, we can detailing about the plaque masses. Okay. Blood test, cardiac enzymes, troponin I or troponin T, CKMP, myoglobin. These are the cardiac enzymes. Lipid profile, blood nitrogen, we can check CRP levels. These are the blood test. Obviously, potassium also. We have to go for the blood test. Okay. Invasive diagnosis text. These are the cardiac catheterization is called angiography, CAG, coronary angiogram. Detects blockages of coronary arteries, measures pressure in the chambers also. Second one is EP study. It's normally focusing on the SA node activities or AV node activities. Electrophysiological study maps arrhythmia origin. Okay, these are some common diagnostic evaluations for cardiovascular disease condition. Again, some common nursing diagnosis: decreased cardiac output, inadequate blood pumped by the heart to meet body's metabolic demands related to altered heart rate, rhythms, impaired contractibility, structure defects. Okay, evidence by. always we have to focus on nursing diagnosis. What we have to focus. One is what is the problem, and that problem can be related to and can be evidenced by. So 3 points we need to keep in mind while making an nursing diagnosis. One is what is the actual problem. Here, the what is the actual problem. You notice a decreased cardiac output. Okay, decreased cardiac output are related to means altered heart rate. Okay, it can be related to altered heart rate, impaired contractibility, myocardial infarction की वजह से cardiac output low हो सकता है, या फिर स्ट्रक्चर डिफेक्ट्स वाल्वुलर डिसऑर्डर्स की वजह से वाल्व जैसे मिट्रल वाल्व प्रॉपर तरीके से काम नहीं कर रहे हैं तो कार्डियक आउटपुट लो हो सकता है. दिस इज रिलेटेड. ओके, एविडेंस्ड बाय. आप उसको कैसे प्रूव करोगे? आपने बोला वाल्वुलर डिसऑर्डर्स की वजह से पेशेंट का कार्डियक आउटपुट लो हो गया है, तो एविडेंस्ड बाय हाइपोटेंशन, weak pulses, dyspnea, fatigue, decreased urine output. So these are the 3 points while we are writing a diagnosis. You have to keep in mind 3 points. What is the exact problem? What is the problem related to? And what are the evidences? Okay. Ineffective tissue perfusion. Okay, what is the decrease in oxygen resulting in failure to nourish tissues are related to yes. Related to diseased cardiac output. Okay, arterial blockages, coronary artery diseases, evidenced by. आप टिश्यू परफेक्शन आपको प्रॉपर तरीके से नहीं है तो आपको एविडेंस कहाँ से मिलेगा? देयर इज अ साइनोसिस. आप पेशेंट का पेरिफेरीज लेको, पेरिफेरीज बहुत कूल है, साइनोसिस की साइंस है, तो वी कैन से इट्स एन इनएफेक्टिव टिश्यू परफ्यूजन. एविडेंस बाय साइनोसिस, कोल्ड एक्सट्रीमिटीज, डिलेड कैपिलरी रिफिल. नॉर्मल कैपिलरी रिफिल कितना होना चाहिए? कितना सेकंड्स के अंदर होना चाहिए? नॉट मोर देन 3 सेकंड्स. 3 सेकंड्स के अंदर कैपिलरी रिफिलिंग होना चाहिए. अब हाथ ऐसे दबा के रखो, ठीक है, आप वापस छोड़ोगे ना तो उसमें अंदर रिफिलिंग होना चाहिए. चेस्ट पेन. Okay, these are the evidences. Okay, activity intolerance related to imbalanced between oxygen supply and demand, generalized weakness, fatigue, evidenced dyspnea on exertion, abnormal heart rate response to activity, report of fatigue or weakness. Okay, acute pain, ischemic tissue damage related to, evidenced by verbal. पेशेंट बोल रहे हैं मुझे चेस्ट पेन है, एविडेंस है. फेशियल ग्रिमिंग्स है, डायफोरेसिस है, ग्रैंडरिंग बिहेवियर है, तो इट्स एविडेंस है. डिजीज फॉर रिस्क फॉर डिक्रीज्ड कार्डियक टिश्यू परफ्यूजन, अगेन related to atherosclerosis, hypertension, diabetic mellitus, स्मोकिंग. एविडेंस में आपको पहले डिस्कस किया था, साइनोसिस और कैपिलरी रिफिलिंग, ये सब आपको एविडेंस लिख सकते हैं. एक्सेसिव फ्लूइड वॉल्यूम related to compromised regularity mechanisms, CHF, renal dysfunctions, मीन्स पेशेंट का इनटेक आउटपुट चार्ट आपको रिलेट कर सकते हैं. आपने देखा पेशेंट का इनटेक ज़्यादा है लेकिन उतना आउटपुट आया नहीं है, तो पेशेंट इज ऑन अ पॉजिटिव. आपने 2 लीटर पानी दे दिया, पेशेंट का आउटपुट उतना 500 ml ही आया है, तो 1.5 लीटर पेशेंट पॉजिटिव में है, तो फ्लूइड वॉल्यूम है. एविडेंस्ड पेशेंट का हाथ पैर में लोअर एक्सट्रीमिटीज में आपको एडिमा दिखेगा, ठीक है, जुगुलार वेन डिस्टेंशन होगा, वेट गेन है, क्रैकल्स इन लेंथ ऑस्कल्टेशंस, ठीक है. इज आर द एविडेंसेस फॉर द fluid oleum, fluid excess oleum. Ineffective coping, diagnosis of chronic cardiac conditions, heart failure, lifestyle changes, evidenced by एंग्जाइटी. इट इज कॉमन है, सभी लोग लिखते हैं पेशेंट अस्पताल में है तो पेशेंट का एंग्जाइटी तो होगा, लेकिन आपको लिखने का एक तरीका होता है, रिलेट करना चाहिए, रिलेट करके एविडेंस्ड. Anxiety is one of the evidence. Verbalization, enough inability to coping, withdrawal. These are the evidences of ineffective coping. Defective knowledge related to lack of exposure or recall, evidenced by frequent questions. आप पेशेंट से बात करोगे तो पेशेंट ज्यादा डाउट पूछेंगे, मेरे साथ क्या हो रहा है, ये क्या होता है, ये गोली क्यों खा रहा है, इससे क्या हो सकता है. तो these are the deficiencies of knowledge. ओके, inappropriate behaviors, खाना नहीं खाता है, ये सब चीज मेडिसिन प्रॉपर तरीके से नहीं खाएगा, पेशेंट बोलते हैं मुझे ये गोली खाने से मुझे डर लग रहा है. दिस आर द डेफिशिएंट नॉलेज. मिसइंटरप्रिटेशंस ऑफ सिम्टम्स. ओके, पेशेंट का ऑलरेडी हाइपोटेंशन है, पेशेंट बोल रहे हैं मुझे तो कोई वीकनेस है नहीं, तो वो रिलेट नहीं कर रहा है, ठीक है. रिस्क फॉर इम्पेयर्ड स्किन इंटेग्रिटीज रिलेटेड टू एडिमा, डिक्रीज्ड टिश्यू परफ्यूजन्स, कॉमन इन हार्ट फेलियर पेशेंट्स. Risk for ineffective health management related to complex treatment regimens, multiple medications, diet, exercises, inadequate support systems. These are the some common and nursing diagnosis, you can make accordingly patient situation. Okay, here comes the disease conditions. Angina pectoris definition. Angina pectoris is a Latin word for wheezing of the chest. The chest discomfort that occurs when there is a decreased blood supply to the area of a heart muscles. Actually, the cardiac muscles, there's a cardiac muscles called myocardial muscles. मायोकार्डियस मसल्स को प्रॉपर तरीके से काम करना है तो ऑक्सीजन डिमांड है, तो अगर ऑक्सीजन वहां पर प्रॉपर तरीके से नहीं आ रहा है, ऑक्सीजन कैरिंग कौन है, ब्लड है, अब वहां पर ब्लड प्रॉपर तरीके से नहीं आ रहा है, ब्लड क्यों नहीं आएगा, वहां पर कोरोनरी आर्टरीज के अंदर ब्लॉकेज है, इफ देयर इज एनी प्लेक, वेयर इज देयर एनी ओक्लूशन, तो वहां पर ब्लॉकेज की वजह से ब्लड प्रॉपर वहां हार्ट की मसल्स में नहीं आ रहा है, तो वहां पे सेल्स नेक्रोसिस स्टार्ट हो जाती है, तो सेल नेक्रोसिस स्टार्ट हो रही है तो इस समथिंग वीजिंग पेन होता है, इट्स कॉल्ड angina. Okay, the major types of angina: stable, unstable, variant, and microvascular. These are the types of angina. Coming to stable angina is the most common type of angina. It occurs when the heart is working harder as usual. Stable angina as a regular pattern. आप टेंशन लेता है, बहुत बहुत हार्ड वर्क कर रहा है, बहुत स्ट्रेस में है, तो हार्ट ज्यादा लोड लेगा, तो इट्स स्टेबल angina. स्टेबल angina इज इन ए हार्ट अटैक, इट्स नॉट ए हार्ट अटैक, वो हार्ट अटैक नहीं होता है, ठीक है, हार्ट मसल्स ज्यादा काम कर रहा है, उसको जैसे उसको मसल्स पेन हो रहा है, बट इट सजेस्ट दैट ए हार्ट अटैक इज मोर लाइकली टू हैपन. अगर उसको आप लाइटली लोगे तो आप वो अटैक में जा सकते हैं. इट्स अ फर्स्ट लाइन सिम्टम है स्टेबल angina. Coming to unstable angina doesn't follow a pattern. वो आपको इंडिकेशंस नहीं देगा, हाँ मैं आने वाला हूँ, मैं दर्द में, अब इस टाइम में दर्द होगा, ऐसा कोई इंडिकेशन आपको बताएगा नहीं, एकदम से दर्द स्टार्ट होगा. इट कैन बी अ रेडिएटिंग पेन, means it can be start from the left side of the chest to radiate into the left hand or to the back or to jaws. It's a radiating pain, unstable angina. Unstable angina is very dangerous and required emergency treatment. This type of angina is a sign that heart attack may happen soon. Means it's a heart attack is ongoing. Okay, so unstable angina. Variant angina is rare. A spasm in coronary arteries causes this type of angina. Variant angina usually occurs while you are at rest, and the pain can be severe. It usually happens between midnight and early morning. Medicine can relieve this type of angina. Okay. This is microvascular angina. Microvascular angina can be more severe and last longer than other type of angina, and medicine may not be relieve this type of angina. The hospital interventions is very required in this situation. Okay. Causes: coronary artery diseases is the primary cause, with a partial blockage or spasm of arteries that supply of blood to the heart. Okay. Anemia, heart valve diseases. Okay. Risk factors: diabetics, family history, high blood pressure, high LDL cholesterol levels, and low HDL cholesterol, obesity, smoking are the risk factors. Signs and symptoms: tightness, squeezing of heart, pressure or ache in the chest, sudden breathing difficulty, sometimes shortness of breath, okay, chest pain similar to indigestion, a choking feel in the throat. There's a choking, the patient feels something like something is obstructing their airway. Chest pain that radiates to the jaw, heaviness, numbness, tingling, or ache in the chest, arm, shoulder, elbow, and hand, usually to the left. A feeling of indigestion and heartburn. These are common types things: heartburn, okay, dizziness or lightheadedness, nausea, vomiting, and sweating, palpitation, shortness of breath are the signs and symptoms. Assessment diagnostic, the findings मैंने आपको already बता दिया है. The ECG is the primary diagnostics. जितना भी cardiovascular disease condition होता है, ECG is the primary one. ECG, TMT, coronary angiogram. Medical management, it can be treated with the nitrates, glycerol titrate, the tablet called sorbitrate. Okay, beta blockers, propranolol, atenolol, metoprolol, pendrol, oxanodol. The most common is using is metoprolol, beta blockers. Surgical treatments, coronary angioplasty, we can stenting the blockages, or CABG. You can, if the blockage is severe, we can go for a CABG, coronary artery bypass grafting. Okay, myocardial infarction, second disease condition. This is the MI. Okay, we can see there are the coronary arteries. Oh, this is a blockage here, and due to this blockage, there is a cyanosis is here. Okay, this is cell death, cell necrosis is happening here. Okay, myocardial infarctions or acute myocardial infarctions, commonly known as heart attack. It is the interpretations of blood supply to part of heart, causing heart cells to die. Okay, causes atherosclerosis, high health cholesterol levels, high blood pressure, diabetics, obesity, and overweight, smoking, hereditary. Signs and symptoms: chest discomfort. Almost all signs are common in cardiovascular disease conditions. Coughing, crushing chest pain, dizziness, dyspnea, shortness of breath. Diagnostic findings same, ECG. ब्लड टेस्ट, हम यहाँ पे ब्लड टेस्ट में आपको ट्रोपोनिन कर सकते हैं, ट्रोपोनिन आई, ट्रोपोनिन टी, या फिर CKMP, ये आप कर सकते हैं. कार्डियक एंजाइम्स टेस्ट करना चाहिए. इफ देयर इज एनी फाइंडिंग्स इन चेस्ट, सॉरी, यानी कार्डियक एंजाइम वहाँ ब्लड में मिल रहे हैं, तो इसे कार्डियक अरेस्ट का साइन है. चेस्ट एक्सरे, कार्डियोमेगाली आप यहाँ पर सीख सकते हैं, ठीक है, या पल्मोनरी एडिमा देख सकते हैं, ठीक है. कॉम्प्लिकेशंस, अरिथमिया, आप प्रॉपर टाइम में आपको मैनेजमेंट आपने नहीं किया, इट्स कैन बी कन्वर्टेड इनटू abnormal ECG एंड कैन बी लीड्स टू डेथ. कार्डियोजेनिक शॉक, हार्ट फेलियर, पल्मोनरी एडिमा, पेरिकार्डिटिस. What is pericarditis? Is inflammation of the pericardium. Okay. Medical management, antiplatelet medications like heparin or any other type of fibrinolytic agents. Nitroglycerin, ACE inhibitors, angiotensin converting enzymes. Inhibitors means cardias is the tablet. Okay, cardias you can use. Beta blocking agents, already I told, beta blocker, we can use metabolor. Coronary angioplasty is one of the treatment line. Coronary angioplasty means PTCA. Okay, yeah, for PCI you can do as a primary, or coronary artery bypass grafting, CABG. Again, congestive cardiac failure. This third condition, heart failure, is called as congestive heart failure. Is a disorder where the heart loses its ability to pump blood effectively. Here comes the ejection fraction. हम 2D को मैं देखा, हार्ट पेशेंट का हार्ट का इजेक्शन फ्रैक्शन 20% है. तो मीन्स वहां पे लेफ्ट वेंट्रिकल के पास पावर ही नहीं है उसको पंप करके पूरा बॉडी में ब्लड पहुंचाने के लिए. तो इट्स कॉल्ड हार्ट फेलियर सिचुएशन. Causes coronary artery disease and heart attack. Silent attack, maybe silent attack हमको पता नहीं चला, 2 बार अटैक हो चुका है. हार्ट एंटायरली हार्ट वीक हो गया है, हार्ट को पावर ही नहीं है, इजेक्शन फ्रैक्शंस बहुत कम हो गया है, तो कंजस्ट उसमें आपको हार्ट फेलियर बोल सकते हैं. कार्डियोमायोपैथी is again one cause. High blood pressure, hypertension, और हार्ट वाल्व डिजीजेस. हार्ट वाल्व डिजीज मीन्स यहाँ पर आपका मिक्सर वाल्व वगैरह डैमेज है, अब लेफ्ट वेंट्रिकल कंट्रैक्ट कर रहा है तो आपको बैक फ्लो हो रहा है, और लेफ्ट वेंट्रिकल ऊपर लोड बढ़ रहा है और पूरा वॉल्यूम बाहर नहीं जा रहा है, तो ग्रेजुअली लेफ्ट वेंट्रिकल की साइज बड़ा हो जाएगा. अब साइज बड़ा हो गया तो लेफ्ट वेंट्रिकल के पास पावर ही नहीं है उसको पूरा ब्लड को पंप करके बाहर भेजे. तो दीज आर सम वाल्व डिसीज कॉसेस, सॉरी, वाल्व डिसीज प्रॉब्लम्स. Congenital again, congenital heart diseases, alcoholism and drug abuse also leads to heart failure. Okay. Signs and symptoms, fatigue, swelling is one of the major. पेशेंट का आप लोअर एक्सट्रीमिटीज आप देखोगे, लेग्स, एंगल ऑफ द लेग और एब्डोमेन आप देखोगे तो लॉट ऑफ एडिमा वहां पर दिखेगा, फ्लूइड कलेक्शन है वहां पर, और increase in the body weight, shortness of breath, increased urination. These are the signs and symptoms of a heart failure. Assessment, diagnostic, again chest X-ray, there will be a enlarged heart वहां पे आपको दिखेगा, और ECG, ओके, वाइट क्यूआरएस कॉम्प्लेक्स वहां दिखेगा. ब्लड टेस्ट, आपको ब्लड टेस्ट में कार्डियक एंजाइम्स वगैरह आप चेक कर सकते हैं, और इकोकार्डियोग्राम, अगेन हार्ट में कोई वाल्व का डिजीज कंडीशन है, एनी वाल टाइप ऑफ वाल्व सिनोसिस और समथिंग लाइक दैट वी कैन सी इन द echocardiogram. Okay, medical management, again, angiotensin second receptor blockers, vasodilators, nitrates, potassium or magnesium, aldosterone inhibitors, calcium channel blockers, angiotensin converting enzymes, beta blockers are the medical managements. Okay, surgical management, see the heart is very weak, below 2, the ejection fraction is below 20, is come to 18 or 17 or 15, a heart transplant is the only one option. Okay, cardiac arrest. This is also, everyone knows what is cardiac arrest. Cardiac arrest or sudden cardiac arrest is a condition in which heart suddenly or unexpectedly stop beating. If it happens, blood stop flowing to the brain or other vital organs. Causes, coronary artery disease is the primary cause. Heart attack, enlarged heart, valvular disease, heart diseases, congenital heart diseases, electrical problems in the heart, or there are some reversible causes also, which can say 5H and 5Ts. If there is any hypovolemia, hyperkalemia, hypokalemia, H plus ions, or any kind of toxins of any pulmonary tension pneumothorax, any pulmonary thrombus, of any coronary thrombus. These are the conditions can leads to a heart attack, sorry, a cardiac arrest. Heart attack or cardiac arrest, both are same? No, both are different. Cardiac arrest is the entire freezing of the heart or entire freezing of the function of the heart, and heart attack means it's a disease condition. Okay, don't confuse with that. Risk factors, okay, who have had a हार्ट अटैक मायोकार्डियल इंफ्रैक्शंस, जिनको पहले एमआई हो चुका है तो रिस्क फैक्टर है, कभी भी कार्डियक अरेस्ट हो सकता है. Who have experienced heart failure, poor pumping of heart, EF ejection fraction 20 to 30% है, कभी भी कार्डियक अरेस्ट हो सकता है. Who have survived a previous sudden cardiac arrest, इनको पहले कार्डियक अरेस्ट हो चुका है, वो इनको भी कार्डियक अरेस्ट दोबारा आने के चांसेस है. अदरवाइज प्रॉपर तरीके से ट्रीटमेंट लेना चाहिए. इन केस आपने मेडिकेशन मिस किया है, दवाई ज्यादा ले लिया, कम ले लिया, आपके पास पैसा नहीं है, दवाई स्टॉप कर दिया है, this will be leads to cardiac arrest with a family history of sudden cardiac arrest. Okay. Signs and symptoms, breathlessness, fatigue, breathlessness on lying down, swollen legs and ankles, decreased exercise of tolerance, enlarged heart, chest pain. These are the primary symptoms, we can say, primary symptoms. There are warning signs. These are the warning signs. Okay. कार्डियक अरेस्ट हो गया तो कुछ सिम्टम्स नहीं मिलेगा, तो आप कार्डियक अरेस्ट मींस पेशेंट अनरेस्पॉन्सिव है, ठीक है, हार्ट इज नॉट बीटिंग, इज पेशेंट इज कोलैप्स्ड. ओके, these are the primary line of symptoms. These are called warning signs. Okay, if the patient have a severe chest pain, severe chest discomfort, any kind of shortness of breath, severe sweating, these are the warning signs of body. Okay. Diagnostics test, again same, echocardiogram. We cannot predict cardiac arrest, but we can identify the baseline causes that can be leads to a cardiac arrest. So echocardiogram, ECG, chest X-ray, TMT, cardiac catheterizations, laboratory studies like CBC, ESR, electrolyte, BUN, creatinine, glucose, TSH, calcium, magnesium, phosphorus, blood cultures. These are the yearly physical checkups can rule out yes, this patient is this much risk for a cardiac arrest. Okay, this is the algorithm of a cardiac arrest. Once I discussed this algorithm in your institutions, I think, okay, what we have to perform if in a patient in a cardiac arrest. One is first you identify the rhythm. Is there a shockable rhythm? Go for a start CPR immediately. Go for a shock, then epinephrine. Okay, this is the algorithm. Okay, if there is a non-shockable rhythm, epinephrine as early as possible, continue CPR. Okay, this is the entire cardiac arrest algorithm. Okay. Medical management, again, the patient is, if the patient is revived, we have to manage medically or surgically, because we need to stop the any chance of cardiac arrest. Okay, the medical management is angiotensin second receptors blockers, vasodilators, nitrates, potassium or magnesiums, aldosterone inhibitors, calcium channel blockers for diastolic or dysfunction only. Okay, inotropic therapy means dopamine or epinephrine or NORAD वगैरह आप यूज कर सकते हैं. डायरोटिक्स, लोप डायरोटिक्स में आपको डायटोर या लासिक्स you can use. Angiotensin converting enzymes, AC inhibitors, you can use for a medical. Surgical, we can go for a coronary coronary artery bypass graft if there is any multiple blockage in the arteries. If there is a LAD block, LCX block, 90% is in LAD or 90% in LCX, there are two major arteries, LCS and LAD. So we have to go for a CABG. Otherwise, one blockage or two blockage, it's not a 70% or 60% blockage. We can go for a stenting. Okay, it's according to the severity of the situation. Okay, heart transplant. Already I discussed. If there is a major heart failure, we have to go for a heart transplant. Okay, valvular diseases. Okay, I already discussed how many valves in the heart. Okay, there are atrioventricular valves and mitral valve, aortic valve, pulmonary valves. So in heart disease, in heart valve disease, one or more of the valves in the heart doesn't work properly. Okay, so one function of the heart is the one side flow. Okay, of the blood. Okay, symptoms: abnormal heart sound, heart murmur. So we nursing students, we are medicos, so we have to listen the normal heart sounds and normal abnormal sounds also. So we don't get more exposure, but we can use YouTube or any other source for listening the abnormal heart sound, heart murmurs, S3, S4 gallop sounds, aortic agitations. Okay, we need to learn what is the ideal landmark where we need to keep the stethoscope for an aorta examination. So this is very important. Otherwise, we can do some physical assessment. Okay. I know you people may know, but you have to practice. Okay. Second is fatigue, shortness of breath, particularly when you have been very active or when you lie down, swelling of your ankles and feet, dizziness, fainting, irregular heartbeat. These are the symptoms. The point is, irregular heartbeat is one of the sign of valvular disease. Okay. Causes. There are so many causes. Heart has four valves that keep blood flowing in correct directions. These valves may include mitral valve, tricuspid, pulmonary, or aortic valve. Each valve has flaps. Flap means leaflet or cups that open or close once during each heartbeat. Sometimes the valve does not open or close properly, disrupting the blood flow through the heart to your body. Okay, the heart diseases may be present at birth, congenital. It can also occur in adult due to many causes of conditions such as infections or other heart conditions, maybe rheumatic fever, something like that. Okay, heart valve problems may include regurgitations. Regurgitation means in this condition, the heart flaps doesn't close properly and causing the blood leakage. One flap opening, one flap is fixed. Okay, this is the thing. So there is a leakage of blood to the contracting chamber. Okay. Stenosis. In valve stenosis, the valve flaps become thick or stiff and they may fuse together. This result in a narrowed valve opening and reduce the blood flow through the valve. So also again, the valve may be thick or stiff, means वहाँ पर movements proper तरीके से होगा नहीं, so it's stenosis. Again the वहाँ पर blood leakage होगा. Atresia, in this condition, the valve isn't formed and a solid sheet of tissue blocks the blood flow between the heart chambers. Means it's a congenital situation है, वहाँ पर proper तरीके से valve form ही नहीं हुआ. So it can be corrected. It's all situations can be corrected through the proper surgical interventions. Diagnosis, history taking, physical examinations. Again, the point is physical examination. पर आपने just auscultation किया है तो वहाँ पर आपने सिर्फ lung sound सुना है, heart sound नहीं सुना है, तो your physical examination is incomplete. So that's why I am saying again and again, I am saying आपको abnormal heart sound सुनना चाहिए और landmark आपको मालूम होना चाहिए स्थल कहाँ रखना है. इकोकार्डियोग्राफी, एकोकार्डियोग्राम, चेस्ट एक्सरे में आपको एनलार्ज हार्ट दिखेगा. कार्डियक एमआरआई, कार्डियक कैथेटराइजेशन में आपको एंटी वाल्व के डिसीज सिचुएशंस आपको समझ में आएगा. ट्रीटमेंट, सर्जिकल हार्ट वाल्व रिपेयर या फिर वाल्व रिप्लेसमेंट आप कर सकते हैं. ठीक है, दिस इज मैकेनिकल वाल्व. ठीक है, मैकेनिकल वाल्व रिप्लेस हम वहाँ पे कर सकते हैं. दिस इज अ टिश्यू वाल्व. टिश्यू वाल्व ऑब्वियसली कॉस्टली है लेकिन उसकी लाइफ एक्सपेक्टेंसी ज्यादा है. ठीक है, तो ये भी यूज कर सकते हैं. नेक्स्ट इज एन्यूरिज्म. Time is running, so I have to run more speed. Aneurysm. Aneurysm's definition: an aneurysm is localized abnormal dilation or ballooning of blood vessels wall, usually an artery, due to weakness in the wall vessel wall. Okay, तो मीन्स इसमें क्या होता है, जैसे आपका जो आर्टरी जा रहा है या वेन जा रहा है जिस भी हो, तो उसमें वॉल वीक हो गया, उसको जैसे उसका बल्जिंग हो जाता है. ठीक है, बल्जिंग हो गया और वीकनेस हो गया और वीकनेस हो गया, वो फटने का भी चांसेस हैं. ठीक है, तो कॉमन लोकेशंस, आयोटिक एन्यूरिज्म्स मोस्ट कॉमन है. abdominal aortic aneurysms, thoracic aorta aneurysms, cerebral vein aneurysms, popliteal artery aneurysm, femoral artery aneurysms is normally वीकेज ऑफ वेसल्स की वजह से होता है ये चीज. causes, atherosclerosis, hypertension, congenital weakness, Marfan syndrome we can say. Trauma or infection, smoking, family history of aneurysm, aging. These are the risk factors or causes for aneurysms. Signs and symptoms, abdominal aorta aneurysms के लिए pulsating of abdominal mass. आप देखोगे तो आपको aorta जहाँ पे आपका abdomen mass में आप देखोगे तो आपको वहाँ पे pulsating टाइप का फील होगा. तो इट्स साइंस एंड सिम्टम्स, abdomen और बैक पेन, ब्लूरिड ओवर द aorta. ऑफन एसिम्टोमेटिक अंटिल रप्चर. ये जरूरी नहीं है हर बार आपको ये सिम्टम दिखाएगा, कभी कभी रप्चर भी हो सकता है. अगर पेशेंट ज्यादा फटीग है तो आपको समझ में नहीं आएगा. thoracic aortic aneurysms, chest pain, hoarseness. आप जैसे आप ऑस्कल्टेशंस करोगे तो आपको वहां पर साउंड सुनाई देगा. ठीक है, difficulty in swallowing, cough and shortness of breath are the most common signs and symptoms of a thoracic aortic aneurysm. Cerebral aneurysm, headache, आपको जैसे ब्रेन में एनेरिज्म है तो वहां पर होता क्या है, वेसल्स डायलेट हो गया, साइज बढ़ गया, तो वो बाकी टिश्यूज को कंप्रेस कर रहे हैं, तो आप पे हेडेक, कंटिन्यूसली हेडेक होगा। जितना भी दवाई खाओगे तो आपको थोड़ा सा रिलीफ मिलेगा, अगेन स्टार्ट होगा। तो इस कंटिन्यूस हेडेक इज अ कॉज ऑफ सेरेब्रल एनेरिज्म्स, विजुअल डिस्टर्बेंसेस, सीजर, लॉस ऑफ कॉन्शियसनेस। ओके, कॉम्प्लिकेशंस, रप्चर, लाइफ थ्रेटनिंग सिचुएशन है। अब देखो एनेरिज्म ब्लस्टर हो गया है तो वहां पर इंट्राक्रैनियल हेमरेज हो गया है, तो इट्स कैन लीड्स टू डेथ। thromboism, embolisms, pressure or adjacent structures, stroke is the complications. डायग्नोसिस टेस्ट, अल्ट्रासाउंड आप कर सकते हैं, सीटी स्कैन कर सकते हैं, एंजियोग्राफी, एक्सरे, ठीक है, आप चेक कर सकते हैं। ओके, लास्ट इज मेडिकल एंड सर्जिकल मैनेजमेंट, monitoring for the small aneurysms. If this aneurysm is small, we can treat them medically. Okay, anti-hypertensive therapies. अगर if the patient is hypertensive, you have to control the hypertension. स्मोकिंग करना है, बैड हैबिट्स है, स्टॉप करना चाहिए। सर्जिकल रिपेयर, ओपन एन्यूरिज्म रिपेयर, फॉर एग्जांपल आयोटा एन्यूरिज्म है, आपको लग रहा है ब्लस्ट होने वाला है, तो यू हैव टू रिप्लेस द आयोटा, इट्स सर्जरी कॉल्ड बेंटाल सर्जरी, बेंटाल। ओके, एंट्रोवास्कुलर एन्यूरिज्म रिपेयर, ओके, दिस आल्सो वी कैन डू। Nursing management, pre-operative and post-operative managements. Okay, pre-operative vital signs, educate the patient, counseling, assess of the pain, pulses, signs of rupture, preparation of the surgery. Post-operative again, monitor for the bleeding. Post-operative में सबसे ज़्यादा important कौन सी है? Monitor for the bleeding, infection. These are the most two post-operative management for surgical patients. Assess of peripheral perfusion, pulses, periphery artery का pulses आपको check करना चाहिए। Manage fluid balance, again important. Pain management important. Encourage early amputations, also important. Health educations, avoid heavy lifting, control blood pressure, smoking बंद करना चाहिए, रेगुलर फॉलोअप होना चाहिए, ठीक है। एंड इसमें मेमोराइज करने के लिए या फिर एन्यूरिज्म के कॉम्प्लिकेशन हमको याद करने के लिए एक तरीका है, इट्स अ ब्लो, bleeding, loss of perfusion, organ ischemia, and weakness of vessel wall. These are the complications of a aneurysm. Okay, hypertension. This is the we can say it's a main. It's called father of CVD. Means ये सबको लेके आता है। अगर एक पेशेंट हाइपरटेंसिव हो गया, ये सारे बीमारी को लेके आएंगे, ठीक है। सो हाइपरटेंशन इज द मेन कॉज ऑफ एंटायर cerebrovascular diseases. Okay, hypertension. According to American Heart Association, defines BP as a force of blood pushing against the wall artery as it is related to blood viscosity and resistance of blood vessels. Systemic blood pressure is the highest arterial pressure when the heart contracts and empties. Diastolic is the lower arterial pressures when the heart relaxes to fill the blood. Hypertension is a disease of vascular regulations in which the mechanism that control arterial pressure within the normal range are altered. Hypertension is diagnosed if when it is measured in two different days. Systolic blood pressure readings of both days above 140 mm of Hg or diastolic pressure readings above 190 mm of Hg, we can say is a patient is hypertensive. Okay, my point is आपको एक दिन आप पेशेंट आपके पास आ गया, आपने चेक किया, बीपी चेक किया, 140 है, हम कंफर्म नहीं कर सकते। 2 डिफरेंट डेज का हमको चाहिए, लगातार 140 के ऊपर बीपी है तो वी कैन से इट्स हाइपरटेंशन। ओके, causes primary or essential hypertension. Approximately 90% of patients with hypertension when the diastolic pressure is 90 mm and systolic is 140 or higher, and other causes of hypertension are absent, the condition is said to be a primary hypertension. There is no other causes for the hypertension. This is a primary hypertension. Secondary occurs approximately 5% of patients hypertension secondary to other pathology. It means पेशेंट को सर्जरी हुआ है, पेशेंट को सिवियर पेन है, तो पेन कैन बी लीड्स टू हाइपरटेंशन, ठीक है। या फिर पेशेंट को सर्जरी होने से पहले आप बीपी चेक करोगे, पेशेंट का बीपी ज्यादा होगा, क्योंकि क्या रीजन है, टेंशन है, टेंशन की वजह से पेशेंट को हाइपरटेंशन है, ठीक है। तो दैट पे हाइपरटेंशन के लिए हमको ज्यादा ट्रीटमेंट की जरूरत नहीं है, ऑटोमेटिकली नीचे हो जाएंगे, ठीक है। जैसे वो आपको भी आता है, ठीक है, फॉर एग्जाम्पल आपको एग्जाम के पहले आपका बीपी चेक करो, ठीक है, तो आपका बीपी बढ़ा रहेगा, ठीक है, इट्स नॉर्मल, सेकेंडरी हाइपरटेंशन बोलते हैं उसको। प्राइमरी हाइपरटेंशन इज कांस्टेंट है, 95% पेशेंट्स को कांस्टेंट है वो में, इट्स कॉन्ट बी रिलेटेड टू एनी अदर डिसीज कंडीशंस, ये खुद का प्रॉब्लम की वजह से हो रहा है, So primary or essential hypertension. Secondary means leads to any other disease conditions की वजह से कुछ time being के लिए हो रहा है, इसको secondary hypertension बोलते हैं. Risk factors, modifiable risk factors include unhealthy diets. Students, ये आपके लिए है, ठीक है, because the risk for the hypertension is very 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 high है. Indian youngsters, आप इंडिया की पूरा स्टडी देखोगे तो ट्रेंड जा रहा है, द मोस्ट यंग कार्डियक अरेस्ट और यंग हार्ट अटैक ऑल वर्ल्ड में सबसे ज्यादा इंडिया में है. लीड्स टू दीस और द प्रॉब्लम्स, ठीक है. ये सब चीज की वजह से हो रहा है. एक्सेसिव सॉल्ट कंजप्शन, ये हाई डाइट हाई इन सैचुरेटेड फैट एंड ट्रांस फैट, लो इंटेक ऑफ फ्रूट्स एंड वेजिटेबल्स, low physical inactivity, consumption of tobacco and alcohol, and being overweight or abuse. इस प्रॉपर डाइट फॉलो नहीं कर रहे हैं, प्रॉपर एक्सरसाइज नहीं कर रहे हैं, तो आप ऑटोमेटिकली हाइपरटेंशन में चले जाएंगे, पता ही नहीं चलेगा. नॉन मॉडिफाइबल रिस्क फैक्टर्स इंक्लूड्स ए फैमिली हिस्ट्री ऑफ हाइपरटेंशन, एज ओवर 65 years, or coexisting disease conditions such as diabetic or kidney diseases. Okay. Signs and symptoms, usually asymptomatic, known as a silent killer. इसलिए मैंने बोला आपको पता नहीं चलेगा, आपका डाइट पैटर्न गड़बड़ है, आप हमेशा फैटी फूड्स खा रहे हैं, फैटी फूड्स और स्लीपनेस नाइट्स है, प्रॉपर तरीके से आप स्लीप नहीं कर रहे हैं. 6 आवर्स तो सोना चाहिए, 6 आवर्स आप नहीं सो रहे हैं, तो ये सब चीज लीड्स टू आपका कुछ कंडीशंस हो सकता है. ओके, सॉरी. Severe hypertension can cause fatigue, nausea, vomiting, confusions, anxiety, chest pains, and muscle tremors. Okay. तो कोई भी छोटा साइंस आपको आ रहा है, कंफ्यूजन क्रिएट हो रहा है, बार बार फैटिग हो रहे हैं, तो आपको हेल्थ चेकअप टेक्स रहे. अदर कॉमन डायग्नोस्टिक इवैल्यूएशंस फॉर हाइपरटेंशन: प्रिवेंशन, reducing salt intake, eating more fruits and vegetables, being physically active or on a regular basis, avoiding use of tobacco, reducing alcohol consumption, limiting intake of foods high in saturated fats, means fast foods वगैरह कम करना चाहिए. एलिमिनेटिंग रिड्यूसिंग द ट्रांस फैट इन डाइट्स, ठीक है. तो ये सब चीज़ आप प्रिवेंट करोगे तो थोड़ा सा हाइपरटेंशन से आप दूर रह सकते हैं. मैनेजमेंट: reducing and managing mental stress, regularly checking blood pressures, treating blood pressure, regular treatment, diuretics, beta adrenergic blockers, lower BP by slowing the heart and reducing the cardiac output, managing other medical conditions. Alpha receptor blockers, lower BP by dilating the peripheral artery vessels and lowering the peripheral vascular resistance, and calcium channel blockers. Next situation condition, rheumatic heart disease, also very important. It leads to any kind of valvular disease also. Agent factors, agent is RSD occurs consequence of RF, which in turn caused by the infections of tonsils, pharynx, adenoids, and group A beta hemolytic streptococci. These cocci are gram-positive or non-motile, non-spore forming, spaced bacilli, arranged in chains. Recently, virus coccyxile B4 is suggested to be a causative organism for RF. Okay. So host factors: age, highest among children between 5 to 15 years of age. They are highly risk people. Sex, both sexes are equally affected. Predisposing factors: poverty, low socioeconomic status, poor housing, illiteracy, ignorance, malnutrition, large families. When the standard of living improves and prevalence of disease comes down. Okay, clinical factors. Fever is a low-grade fever which may last for about 3 months. Not this point. Low-grade fever about to 3 months. Okay. Polyarthritis, inflammation of major joints like ankles, knees, elbows, and wrist occurs, which becomes painful. Subsides spontaneously within about a week. The pain migratory in nature, and that is, as it subsides in one joint, it appears in another joint. Okay. Carditis, nearly 60 to 70% of cases, the heart is affected. Pericardium, myocardium, valves are involved. Most commonly, valves are involved. Tachycardia and cardiomegaly and heart failure can occur. Damage to the mitral valve is permanent. Okay. Manifestations, major manifestation is carditis, polyarthritis, subcutaneous nodules, cholera, erythema migratum. These are the major manifestations. Minor manifestations is fever, polyarthritis, raised electrolyte sedimentation rate, or leukocytes. So ESR rates we can correlate with this RSD. Okay, preventions is a primary prevention. Health promotions, prevention of malnutrition in children, improving living conditions and general sanitations of house or surrounding environment. Housing standard should be improved to avoid overcrowding. Health educations to people to report sore throat as it is can be due to beta hemolytic streptococcus, which can cause rheumatic fever. Proper approach to higher risk groups such as school-age children, they should be kept under strict surveillance for streptococcal pharyngitis. Ideally, sore throat swab to confirm the diagnosis should be cultured. Those found positive should be treated. Okay, secondary preventions aims at the prevention of recurrent attack of RF, especially in developing countries. Detection of cases that have RF by conducting surveys, they should be treated by one dose of 1.1 million units of penicillin to adults and 6 lakh units to children at 3 weeks interval. This must be continued for at least 5 years or until the children reaches 18 years of age, whichever is later. And the tertiary prevention, disability limitations. Patients who have already developed RSD can have disability due to joint pain and carditis. This can be prevented by giving treatment with aspirin for joint pain and treatment with penicillin for life for carditis. Surgical interventions also may be given to case of mitral stenosis, mitral valve replacements we can give. Okay. Rehabilitations, patients suffering from RSD are given social, vocational, and psychosocial, psychological rehabilitations. For example, if the patient have a mitral stenosis, his or her capacity for physical activity is lowered. He or she has to be rehabilitated to choose another occupations if she are engaged in occupations requiring hard physical labor. Okay. Thank you. I think I'm on time finished. Yeah, this is any
Thank you,
answer
sir.
question section.
Thank you, sir. If anybody have question, kindly ask. Chat box is open.
I think it was a good sleep for all children. Any feedback from students? Can I expect one feedback from a student?
किसी के पास कोई question है? You can ask.
I know I run very fast. ECG, so this is just a miracle. Just create an interest and go for refer books. आज घर जाओ, YouTube देखो, जो मैंने सिखाया पढ़ाया, जो बोला सही है क्या नहीं चेक करो. Focusing on the heart sounds, lung sounds. Okay, सुनना चाहिए, auscultate करो. आपके मैनिक्वेंस नहीं है, डजेंट मैटर. आपके मोबाइल में हेडफोन लगाओ, सुनाओ. हार्ट साउंड, लंग साउंड आपको यूट्यूब में मिलेगा. और लैंडमार्क्स मालूम होना चाहिए कहाँ पर आपको स्थो रखना है. अस्पताल जाओगे तो आप देख लो. आईसीयू में जाओ, वेंटिलेशन के पास जाओ, स्थो रखो, आपको लंग साउंड, हार्ट साउंड सुनाई देगा. वेरी इंपॉर्टेंट. ईसीजी इज ऑल्सो वेरी इंपॉर्टेंट.
Sir, there is a question and answer box. There is a question from one student. So,
यस, ऑब्वियसली अगर आप देखो, आप टीएमटी कर रहे हैं तो आपको हार्ट को अब लोड दे रहे हैं. ठीक है, लोड दे रहे हैं तो बीपी तो बढ़ेगा. ठीक है, आप बीपी बढ़ रहे हैं, अगर 140 क्रॉस कर रहे हैं तो आपको टीएमटी बंद करना चाहिए. ठीक है, तो आइडियली नॉर्मल पर्सन है तो उसका भी बीपी थोड़ा सा बढ़ेगा, लेकिन 140 150 तो क्रॉस नहीं करेगा. इन केस एनी डिसीज कंडीशन है तो उसका बीपी बढ़ेगा. ठीक है, और इसलिए बोलते हैं आपको एवरी एवरी 5 मिनट्स में आपको बीपी चेक करते रहना चाहिए टीएमटी करते हुए. अगर आप बीपी चेक नहीं करोगे तो पेशेंट कोलैप्स हो गया, पता नहीं चलेगा. बीपी वेरीज है, अब बड़ा बीपी ज़्यादा भी हो सकता है, कम भी हो सकता है. बीपी ड्रॉप हो रहा है, पेशेंट फील फेटिक, आप तुरंत टीएमटी बंद करो. आप भी उसको वाइटल चेक करो, समथिंग फाउंड फिशी, शिफ्ट द पेशेंट टू आईसीयू एंड क्लिनिकली आप उसको ट्रीट करना चाहिए. ठीक.
else anyone have question? So, thank you, sir. Good afternoon, everyone. Am I audible?
You are audible.
So I'm good afternoon, everyone. I'm Manisha Angelina David, Associate Professor, SINPS. So as we come to end of the day one of our national webinar series on redefining nursing practice, focus on adult health and surgical care, it is my privilege to deliver the vote of thanks on behalf of SINPS. First and foremost, a sincere thanks to our respected principal, ma'am, Dr. Deepti Shukla, ma'am, for being the pillar of support and providing constant encouragement throughout the planning of this webinar series. We are deeply thankful to our keynote speaker, Professor L.B. Paul, sir, for the enriching session and for sharing their expertise on today's topic. Your contribution has truly set the tone for the sessions ahead. A warm thank you to all our faculty members, students, and participants who join us from various institutions and made this event successful with your enthusiastic presence and active participation. We look forward to welcoming you all again tomorrow for day 2 of the webinar series. Until then, stay safe, stay curious, and keep learning. Thank you and have a wonderful day ahead. Thank you.
Thank you, Manisha. After finishing, thank you, LB. It was a wonderful class. I also listened. So, though I am not from your department, but I really enjoyed your class. I know that you are a wonderful teacher. You are a fantastic person who can teach cardiovascular. And when I thought about the cardiovascular, none came in my mind except you. So, thank you so much for receiving a call from my side and saying yes to be presented as a presenter today. And it was really a brilliant presentation. I could see in the chat box, you also can see that there are many people are saying excellent class. So a big clap for LB Paul sir, that he really did a wonderful job to explain about all the waves. So अभी हम सब लोग waves में तैर रहे हैं, and he said you have to go with the phone and audio clips and just find out. You can feel the sounds everywhere, everything. So that's good. You can go with the practice. And as you have seen in Uttar Pradesh, you maximum colleges you visited in your personal means official tour. So you know that there are many kids now, but let the students start learning.
Yes,
From
ma'am.
Samarpan.
That's indeed. That's indeed.
Yes, they need to be motivated for the learning. From Samarpan, we are trying to give an expert lecture to each and everyone who wanted really to join, because I know that every colleges they don't have much expert. Even our college also we don't have much experts. So this is a combined venture that students can learn from our side and we can learn from you people. So that is a good platform to being having this webinar series. So today you just give a boost to the students, and this is starting one, and the दिल से start किया है, means cardiovascular से start किया है. So ये बहुत अच्छा था. Thank you so much. And future also we will be in the joint venture, and I know that you will be joining in the next coming lectures related to the cardiovascular and medical surgical. Thank you, Albi, on behalf of all the entire teaching fraternity of Uttar Pradesh, that you really did your job in very corrective way. Thank you so much for presenting today. And all the participants, tomorrow on 27, we have another wonderful and fantastic expert, Dr. Arpana Pandey, madam. Arpana Pandey. So she is taking digestive disorders 50%. Means half disorders she will cover, and half disorders will be covered by Mr. Rahul K. Sharma on 2nd June. So please be on time, 2 o'clock. I can say same channel, Zoom, and same college, Samarpan. Thank you for being the part of this series. Take care, stay blessed. मैंने सुना है कोविड आ गया है, तो ये सुनना ही होना चाहिए था. आप लोग सब लोग अपना अपना ध्यान रखिएगा. बी सेफ. हाथों को भी आराम से साफ सुफ रखिए, मास्क वास्क लगा के रखिए. कोविड के नाम से ही डर लगता है, लेकिन होपफुली सब कुछ अच्छे से निकल जाएगा. अच्छे से रहिए, हेल्दी रहिए. टेक केयर. जय हिंद. बाय बाय.
Thank you, ma'am.